colleagues, in partnership with the Österreichische Gesellschaft für Nephrologie, the Deutsche Gesellschaft für Nephrologie, and the Société francophone de Nephrologie, Dialysis et Transplantation, Marcus at Home welcomes Dr. Parker Gregg in Houston, Texas, with whom we would like to discuss the issue of fatigue in patients with kidney disease. Dear Parker, thank you so much for joining us. We're very happy to host you this Austrian evening while it's high noon in Texas. Dr. Gregg is nephrologist and assistant professor in the Department of Medicine of Baylor College of Medicine in Houston, Texas. Dr. Gregg's major fields of clinical and academic interest are depression and fatigue in patients with chronic kidney disease, CKD, health outcome research and nephrology, and non-traditional cardiovascular risk factors in CKD patients. My co-moderators tonight are Professor Markus Säemann and Professor Andreas Kronbichler from Vienna and Innsbruck in Austria.
Thank you so much for having me. I'm honored to be here, and I'm looking forward to talking with you all this afternoon about fatigue in patients with kidney disease. So I would like to open with this quote from a patient on maintenance hemodialysis who said, "When I started dialysis, I couldn't lift a coffee pot." For me, this really illustrates how severe and limiting fatigue can be in patients with kidney diseases. Fatigue is important to our patients, and it affects their lives. And to help them feel better, we need to have a better understanding of what causes it and what we can do about it. So I would like to briefly cover measurement and epidemiology, pathophysiology, and management. So starting with measurement and epidemiology, we do not have a concrete definition of fatigue in patients with kidney disease. This symptom constellation is complex and multidimensional with both physical and psychological components. These symptoms can be severe, pervasive, and relentless. Fatigue may even be so severe that it can interfere with a person's ability to function. Because fatigue is a subjective experience for the patient, we typically measure it on self-reported measures using Likert scales. There are several measures out there, and the priorities of what you want out of a measure differ depending on your setting. So in clinical practice, you may want to prioritize a short, simple measure that captures severity and impact on participation in life activities. The Song HD group created a measure like this that is a good choice for the clinical setting. It has these 3 questions on a scale of 0 to 3 and is very simple and easy to administer. So in the research setting, where we are still trying to better understand underlying mechanisms of fatigue, the priorities may be a little bit different for a measure. So a multidimensional measure that captures different aspects of fatigue may be more useful in this context. The 2 most commonly used are the FACIT fatigue, which is a 13-item questionnaire, and many studies also use the vitality subscale of the commonly used short form 36 quality of life measure. Several studies have reported fatigue on self-reported questionnaires and found that about 2/3 to 3/4 of patients with non-dialysis CKD report some degree of fatigue. In this figure, the gray bars show you fatigue that was reported without specifying the severity, and the blue bars show you in light blue fatigue that was categorized as mild to moderate, and dark blue represents severe fatigue. As much as 24% of reported fatigue may be this severe, debilitating form of fatigue. And in patients who receive hemodialysis, they may also experience fatigue related to the dialysis treatment. So there have been several studies looking at the development of fatigue after dialysis, in which at least half of people on hemodialysis are experiencing some degree of fatigue after dialysis that requires at least several hours and sometimes even half a day or more to recover from the dialysis session. In addition to the importance of fatigue itself and its impact on patients' lives, patients with fatigue are more likely to experience adverse clinical outcomes. So this is a figure from a prospective cohort study showing that among patients with CKD stages 2 to 5 who reported fatigue at baseline were more likely to experience the composite of death, dialysis initiation, or hospitalization within 1 year. So the key points that I want to communicate about the measurement and epidemiology is that fatigue may mean different things to different people, that the ideal measure that you would use depends on the context in which you're trying to implement it, that the majority of patients with kidney disease would report fatigue if you were to ask them, and that fatigue is associated with adverse clinical outcomes. So let's move on to the pathophysiology and really discuss some of these factors that impact fatigue in patients with CKD. Fatigue is multifactorial, and there are likely different factors at play in different patients. I'm going to review some of the contributing factors that have supporting data divided into 3 categories: oxygen delivery, sarcopenia and skeletal muscle function, and other factors. Factors affecting oxygen delivery are likely a major contributor to fatigue. Many of us are probably aware of the association of anemia and decreased oxygen carrying capacity with fatigue, but let's dive a little bit deeper into those relationships. So patients with CKD have higher levels of fatigue at low levels of exertion. So on this figure, on the x-axis, you see different levels of activity intensity measured in METs, and on the y-axis is perceived exertion. The level of exertion reported here are equivalent to activities such as ironing, food chopping, and putting away items. And even at these relatively low levels of exertion, patients with CKD reported higher levels of fatigue than healthy controls. And they also developed lactic acidosis even at these low levels of exertion. So for levels of activity as strenuous as food shopping or putting away items, patients with CKD had higher blood lactate levels, even exceeding 2 millimoles per liter. This study also showed that patients with CKD had lower levels of oxygen delivery during exertion, largely driven by lower hemoglobin levels, which is a known contributing factor to fatigue, but the lack of compensatory increase in cardiac output or oxygen exchange ratio to account for oxygen delivery needs during exertion also likely contributes. So, this is a study looking at oxygen extraction in patients with CKD. This table shows the proportion of hemoglobin that is oxygenated in CKD and non-CKD patients, both at rest and with exercise. And although this didn't reach significance, it does suggest that patients with CKD may have a decreased ability to extract oxygen from the blood to use in exercising skeletal muscle. Patients who receive hemodialysis may also have additional cardiovascular effects of the dialysis treatment itself, which include the fluid shifts related to the ultrafiltration volume, intradialytic hypotension, and intradialytic cardiac ischemia, also known as myocardial stunning, that may impact their experience of fatigue during and after the dialysis treatment. I feel like one of the factors that I get asked about most often is the relationship of fluid shifts with fatigue in patients on dialysis. And anecdotally, many patients will say that they feel more fatigued if they have more fluid removed on dialysis. So here are some data to look at that relationship. These data are from DOPS, so this is all observational, but they did show that every 1% increase in intradialytic weight loss was associated with a 4% increase in a longer time to recovery after dialysis. But when they looked at this relationship categorically, looking at ultrafiltration rate, as less than 5 to 15, and greater than or equal to 15 milliliters per minute, they found that patients with the lowest and highest ultrafiltration rates actually were less likely to experience a longer time to recovery after dialysis. But keeping in mind that these are observational data, you have to think about how the people who had the highest ultrafiltration rate may have been selecting for the people who could tolerate the highest ultrafiltration rate. And so that's a piece of this question that we have yet to tease out totally clearly. So moving on to sarcopenia and skeletal muscle function, I'd like to talk a little bit about protein energy wasting, metabolic acidosis, and hyperphosphatemia as they pertain to fatigue. In the setting of worsening kidney disease, protein energy wasting encompasses the chronic inflammation, malnutrition, protein catabolism, and metabolic and hormonal abnormalities that go along with loss of kidney function. The loss of skeletal muscle mass, also known as sarcopenia, is one of the most concerning consequences of protein energy wasting and is strongly associated with both fatigue and poor physical functioning. The Protein energy wasting syndrome includes several metabolic abnormalities that are common in patients with CKD and can affect skeletal muscle function and sarcopenia. A metabolic acidosis can contribute to increased muscle breakdown. And so here you see that lower serum bicarbonate levels are associated both with lower gait speed, shown on the left, and with functional limitations, shown in the table on the right. And hyperphosphatemia is another factor that is common in patients with CKD that may impact skeletal muscle function. So intracellular calcium is necessary to expose myosin binding sites for excitation contraction coupling and skeletal muscle contraction. And elevated intracellular phosphorus may contribute to skeletal muscle dysfunction by binding up intracellular calcium, leading to a decreased ability to contract the muscle. And finally, I'd like to touch on depression and obstructive sleep apnea as factors that are very common in patients with kidney disease and likely contribute to subjective feelings of fatigue. So another quote from this patient who's on hemodialysis who said, "Depression and dialysis go hand in hand. At one point in time, all of us have been deeply depressed." Depression is present in about 21% of patients with chronic kidney disease. And of course, fatigue is one of the diagnostic criteria for depression. So these two entities often coexist. But the relationship between fatigue and depression in kidney disease is likely more complex as part of the protein energy wasting syndrome that links malnutrition and inflammation with depressive symptoms. So for example, elevated levels of the inflammatory biomarker high sensitivity C-reactive protein have been shown to be associated with fatigue and other somatic symptoms of depression, suggesting that underlying inflammation in patients with kidney diseases may contribute to feelings of fatigue. And finally, I wanted to touch on obstructive sleep apnea, or OSA. OSA is present in 40 to 64% of patients with CKD. It's very, very common. And many of us are familiar with the mechanism of fluid overload contributing to this. So when a fluid overloaded patient lies down, that fluid goes to their neck and can contribute to airway obstruction. But there are additional mechanisms at play as well. So CKD generates metabolic acidosis, which can contribute to hyperventilation and hypocapnia, and this can enhance chemoreflex sensitivity. The alteration in chemoreflex control and reduction of PCO2 can both destabilize sleep respiratory control and contribute to sleep apnea. This is by no means an exhaustive list of factors contributing to fatigue, but at least these are some of the likely contributing mechanisms that have plausible supporting data. So a couple of key points that I want to leave you with about the pathophysiology is that there is no clear or simple explanation for what causes fatigue. Anemia, cardiovascular disease, protein energy wasting, acidosis, and hyperphosphatemia may all contribute to muscular fatigue, and depression and sleep apnea may also have effects on a subjective experience of a low energy level. So finally, let's talk a little bit about management. And here I want to bring in another quote from Dr. Perchinsky, this patient on dialysis, who said, "Exercise and proper nutrition brings life to me, and it gives me the energy I need to somewhat be functional throughout the day." This statement is so powerful to me, and I think it really highlights the importance of exercise and diet in trying to help people feel better, but it also highlights that even that is getting him to a point of being just somewhat functional. It doesn't make this problem go away entirely, but it is very helpful and very important. So exercise is probably the most important thing we can recommend to patients with fatigue. I've only selected one study to show you here, but there are several small clinical trials showing a benefit of exercise, whether cardiovascular or weight training, on both measures of physical functioning, such as the 6-minute walk test, as well as on patient-reported fatigue severity. Typically, I recommend to patients that any activity is better than none, and many will start with walking as they build up their stamina and they can work their way up to higher levels of exertion. Treatment of anemia with erythropoiesis stimulating agents, or ESAs, may also help in some cases. You may already be familiar with the results of the CREATE and TREAT trials showing that the management of anemia with ESAs led to a modest but greater improvement in patient-reported fatigue, as shown here. There is an ungraded recommendation in the KDIGO guidelines that individualization of ESA therapy to achieve a higher target hemoglobin is reasonable to achieve improvements in quality of life in some patients, but this has to be considered very carefully in light of adverse effects as well. More recently, the HIF-alpha inhibitor daprodustat has also been shown to modestly improve fatigue compared to placebo. Here I am showing you the fatigue levels on the y-axis with the daprodustat group shown in orange and the placebo group shown in blue. And you can see that as early as 8 weeks after randomization and persisting to 28 weeks, the daprodustat group had greater improvements in fatigue scores. Regarding metabolic acidosis, several studies have evaluated the impact on functional status and muscle size with mixed results. Here I'm showing you data from a few studies that did show a benefit of alkali supplementation on sit-to-stand time and on mid-arm muscle circumference. On the left, you can see that sit-to-stand time improved by 1.6 seconds on average after bicarbonate supplementation. And on the right, you can see that mid-arm muscle circumference increased at 12 and 24 months in those on bicarbonate compared to those not on bicarbonate. However, there are also other studies arguing against the impact of alkali supplementation on muscle size, functional status, and on patient-reported fatigue. So it is less convincing to me that alkali supplementation may be profoundly helpful, but it is a potential intervention that might help patients feel a little bit better. And finally, a word about the treatment of depression. So the data are a bit mixed about sertraline, which is a selective serotonin reuptake inhibitor for fatigue in patients with kidney disease. The CAST trial, the chronic kidney disease antidepressant sertraline trial, was a trial comparing sertraline to placebo in patients with non-dialysis CKD. And it did not show a difference between the sertraline and placebo groups in the change from baseline to study exit in patient-reported fatigue. But the ASCEND trial, which compared cognitive behavioral therapy to sertraline in patients on hemodialysis, did show a higher, in other words, a more favorable fatigue score in the sertraline group compared to the cognitive behavioral therapy group at 12 weeks. That may support a possible benefit. And then more recently, the Take Care study, which was published last year, was a clinical trial of a cognitive behavioral therapy and or pharmacotherapy intervention. And one of their symptoms of interest was fatigue. And they found that the intervention led to an improvement in fatigue scores both at 3 months and at 6 months, but by 12 months, that difference was no longer present, so it didn't last. And then a few other items. So there are some questions about how we might modify patients' dialysis prescriptions to see if we can achieve better quality of life and less fatigue. And there have been some studies that suggest some interventions, but they have limitations as well. So short daily dialysis treatments is one intervention that's been shown to improve fatigue. But another quote from Dr. Burczynski is, who would have time for that? It's difficult to implement for a lot of patients. And sodium modeling, again, had some potential benefit to fatigue, but this is limited by thirst and weight gain. And finally, lower dialysis temperatures. The data are a bit mixed about whether this achieves benefits in fatigue, but the limitations by tolerability also make this a bit more difficult to implement for a lot of patients. So a couple of key points about management. Physical activity is the intervention that has been shown in clinical trials to consistently improve fatigue and functional status, and we should be recommending this to people. Erythropoiesis stimulating agents may be used to target higher hemoglobin in appropriate patients, considering the potential risks that go along with that as well. So it's not something that should be used indiscriminately, but it is an option that we have in our toolkit. And finally, the treatment of metabolic acidosis and depression might be helpful as well. So to just put this all together in a conceptual framework, many interrelated processes contribute to fatigue in patients with kidney disease, including anemia, cardiovascular disease, impaired skeletal muscle function, depression, and insomnia. These combined factors work together to generate lactic acidosis with exertion and contribute to protein energy wasting and sarcopenia through inflammation and various metabolic abnormalities. Depression, sleep apnea, and the use of central nervous system depressant medications may also contribute to subjective feelings of fatigue. Management of these individual components with erythropoiesis stimulating agents, alkali supplementation, and the treatment of depression and sleep apnea may help. But exercise may benefit multiple of these pathways and is the intervention that has been most consistently shown to benefit patients and improve fatigue. So this is what I tell patients who come to see me and tell me that they're feeling fatigued. First, I think it's important to acknowledge that fatigue is common among patients with kidney disease, because just acknowledging this with patients often helps them feel validated and they're not alone in feeling this way. Fatigue is associated with a lot of different factors, and there may not be one single underlying cause. But we will look at a bunch of possible causes and treat what we can, including anemia, acidosis, insomnia, hyperphosphatemia, sleep apnea, and depression. But at the end of the day, engaging in exercise is the thing most likely to help them start feeling better. So with that, I will happily take your questions.
Barker, that was really great overview over the topic. Do you have any experience if, for instance, our patients on dialysis are not really motivated to exercise on their own? If sports during dialysis is helpful, and do you have a dedicated program at your center?
That's a great question. So a lot of the studies that have been done, the interventions have actually been quite varied. So there have been some intradialytic exercise, which is typically an intradialytic cycling exercise, but there are others that involve exercise on non-dialysis days. And at the end of the day, there isn't really compelling evidence to suggest that any one is better than another. Really, I think the right kind of exercise to recommend for people is what they will actually do. And anything is better than nothing. And so really starting simple. I mean, if you just tell somebody that they need to start going to the gym for 2 hours a day, they're not going to do it. And so you're not going to achieve any benefits from that. So I think meeting people where they are is very, very important to having some success here. Where we are, intradialytic cycling is something that I think gets talked about a lot, but it's not really widespread implemented in the United States. As far as I'm aware, I think that would be a difficult thing to do to scale. And so I tend to focus more on what they can do outside of their contact time with the healthcare system.
Yeah, I think the patient you referred to in your presentation, when I listened to the podcast, it's quite impressive because he really runs through a journey, and he's really driven to go to the gym, I think, on non-dialysis days. So 6 times a week dialysis wouldn't be a very good option for him. So if somebody is really, telling you, I don't know what to do anymore, I'm so fatigued and none of these measures is helping, would you recommend then going on a dialysis regime, which is like 6 times a week?
It sort of depends on the individual patient, as you were, alluding to. Each individual patient is going to have treatments that are more or less acceptable to them. They may or may not have access to 6 days a week dialysis. I think a lot of it just depends on what you're able to recommend to someone. But I think if 6 days a week dialysis is an option, so for example, if someone could switch to a home hemodialysis modality, that they could have a little bit more control over when and how they get their dialysis done, then that would be very reasonable to recommend for somebody who has not really achieved acceptable benefit in fatigue.
So coming back to the beginning of your presentation, you were referring to the different questionnaires you can do to assess fatigue. So what are you doing in your clinical practice, or which one do you use?
The Song HD questionnaire is a very useful one, but it has been validated in patients on dialysis. So it's hard to know if that one's as applicable to patients with non-dialysis CKD. I think for a dialysis shift, it's a great choice. For non-dialysis CKD, I tend to, in the clinical setting, focus on the fatigue items that are embedded within questionnaires assessing other symptoms. So if you're using one of their, I listed them as abbreviations because I didn't want to get bogged down in the weeds about what all of those questionnaires were, but there are lots and lots of questionnaires to try to assess general symptom burden in patients with CKD, and most of them will have a fatigue item in them. Ultimately, though, any of these questionnaires is really a screening tool, and nothing replaces the conversation that you have with a person about what they're experiencing, and trying to get a sense of whether they have more of a muscular fatigue or a cognitive fatigue, or if it's more of a depression phenotype, or if they're having daytime sleepiness. I mean, all of these things are very different from one another that may not be captured simply by a question that just says, "Hey, are you tired?" So ultimately, that's the key, is talking to them.
And how well is fatigue actually correlating with pruritus of your patient? Because that's been an issue, for most of the patients in our center.
I think you see both very commonly, although it's hard to say how well they correlate, just because so many patients on dialysis experience such terrible fatigue. I couldn't tell you if those two specifically tend to go hand in hand. It's just the overwhelming majority of patients on dialysis experience fatigue.
Yeah.
And so I wouldn't be surprised if people who have pruritus also have fatigue, but that may not necessarily mean they're interrelated.
And is there any data actually, you mentioned the Brutustat as a new option. Is there any head-to-head comparison between EPO and HIF-PHIs?
Not that I have seen. I'm curious to see if something like that will ultimately come out. I would be really interested to see if there is something mechanistically about these individual agents, rather than simply raising the hemoglobin target to a higher level, that impacts fatigue. But I'm not aware of any head-to-head comparison data on this question.
We had a very nice Marcus at home a couple of months ago, actually, when we learned that SGLT2 inhibition is sometimes very helpful to raise your hemoglobin. Is there any data that SGLT2 inhibition is actually improving fatigue in the non-HD population?
So I'm really looking forward to seeing more of that question come out. And I think that there are a lot of potential reasons that those could be helpful. So in large measure, I think getting patients started on those agents early enough to slow the progression of their CKD and just prevent their disease from worsening is going to be humongously impactful. But also the cardiovascular benefits in general. I strongly suspect that underlying cardiovascular disease is largely related to why our patients get so fatigued. And if SGLT2 inhibitors are leading to these remarkable chronic cardiovascular effects, then I'm quite hopeful that we'll see major impacts in that way. But I don't know of specific trials that have come out, really officially expressing that.
Just to conclude, Andreas, sorry, this anemia section, do we have any data on iron in this context? Because, the clinical issue is surely some patients do have benefit when it comes to fatigue when we raise their hemoglobin with EPO, but we always are surely somewhat concerned of the adverse outcome that has been suggested in some phase 3 studies. Whereas with iron, we do have a good study that shows that there's benefit for our patients. But do we have good data on fatigue here?
So there are great data on fatigue in other patient populations, that iron supplementation is actually very beneficial in improving symptoms of fatigue. I would argue that perhaps we are undertreating iron deficiency in our patients, given that the criteria for diagnosing iron deficiency are like quite a bit different in our patients than they are in the general population. And so we probably have a lot of patients who would meet kidney disease criteria for iron deficiency who may not kind of come to the attention of healthcare providers for having iron deficiency. And I suspect that would be a high yield area to intervene upon to help patients feel a bit better. It is something that I look for and do treat in my patients.
From my side, first, thank you for this really interesting presentation. I think this topic is much more complex than molecular immunology or signal transduction. So I'm seeing every day fatigue in my clinic, but I'm not aware of the scientific evidence about that. So therefore, sorry for my questions. I have two questions because fatigue is so, I think, complex because it entangles subjective and objective parameters. And what is the root cause and what are the effectors? Because sarcopenia could be an, so to say, effect of fatigue and could then bounce back and further enhance fatigue. So like in an analogy to migraine in neurology, could there be subtypes of fatigue that maybe accumulate in one patient? Because we know that post-dialysis fatigue is a clear, so to say, physical phenomenon that we can see. So should we speak about different types of fatigue possibly? And second, are you aware prospectively, so to say, we see patients before they come to dialysis and CKD stage 5, they have fatigue, then often they feel better. So something maybe goes on with uremic toxins acting on the central nervous system. And if I look at the CFS field now, the chronic fatigue syndrome, they focus a lot on imbalances of neurotransmitters and these kind of things. So where could there be the root cause of, so to say, CKD fatigue?
Yep, all of those things are really good questions. So the first question was about subtypes of fatigue, and I absolutely agree with you. I think that asking people, are you tired, and giving them a Likert scale is not enough to capture what's going on, because there are so many different things that could mean. Now, whether there's a direct relationship between sort of these phenotypes of fatigue that might manifest more as like a muscle weakness, poor physical functioning, cognitive fatigue, depression, sleepiness, all of these things are very different. Whether they tend to relate to different underlying causes, we have yet to figure out. But I think that would be a very compelling thing to try to figure out, because if we could more easily glean information from a history and physical exam that could guide our treatment strategies, then that would be really useful. Your second question was, remind me, please.
Yeah, I wanted to know whether there's somehow, because patients, when they are in CKD stage 5, they experience fatigue. And then often sometimes it resolves and they start dialysis, they feel better, fatigue goes away. So giving lend to the support to the hypothesis that there could be uremic toxins acting on the central nervous system. And then maybe it starts again after 1 or 2 years. So do uremic toxins have a role in the fatigue? And then maybe it becomes exchanged with another kind of fatigue when they are already on dialysis.
So I think the answer to that is maybe, or at least probably in some people. So when you talk about patients who are transitioning from non-dialysis CKD to dialysis, some of them feel better, some of them feel worse, and some of them don't change how they feel in terms of fatigue. And it's very hard to predict who's going to be who. So I think it's likely or possible that uremic toxins and perhaps a volume overload that we address once we can start ultrafiltering someone could be contributing to a patient's fatigue. But it's clearly not 100% consistent across all patients that they feel better when they start dialysis. And I don't think that we've really teased out exactly why that may be the case. Your statement about neurotransmitters really interested me. There are some data about that, about branched chain amino acid depletion in patients on dialysis and how they can compete with tryptophan in the central nervous system. And so if you dialyze those away, then the patient might have more tryptophan affecting their CNS and could contribute to fatigue. Again, this is something that has a little bit of supporting data. It's very interesting, but all of these factors, and what makes the fatigue research landscape so complicated is that any of these studies, the signal to noise ratio can be really hard to tease out what's a real effect. And I think that you're getting back to your question about identifying different subphenotypes of fatigue. I'm optimistic that could be really useful in trying to parse out some of these different potential underlying mechanisms and therefore different treatment strategies.
Yeah, it's interesting because it's funny that today one of my physicians asked me whether I know a chronic fatigue specialist for one of our outpatients in our ambulance, and because it's somehow an exploding field. We read it all the time in the media and after COVID and so on, and how to define it. And honestly, I couldn't find a CFS specialist. I thought they reside in the neurology arena, but obviously a lot of this is going on in the scientific field, and maybe there's some kind of synergy for you, with chronic fatigue syndrome. I don't know how they would, because at the end of the day, I said, what would they do with them? I don't know about any kind of treatment for CFS. I mean, this patient had 2 creatinine and this is just CKD stage 3, but nevertheless, it's an obvious need, for therapy there.
I completely agree. And, I'm so glad that fatigue is coming more to the attention of clinicians, because I feel like this has been a very important problem to patients for a long time. And so I'm glad that as a field, we're kind of coming around to recognize that this is very important that we address and treat.
Yeah, I think this is the reason why every second patient over 60 has a serotonin uptake inhibitor. So it's a wild epidemic, maybe also in the US, that everybody has an SSRI because physicians are not competent to treat the fatigue, and therefore they get antidepressants.
Well, and that's non-trivial either, because those carry risks with them, particularly the ones that can prolong the QT. And anyway, that's a conversation for another day, but it's non-trivial.
It's just a symptom of that we do not know how to diagnose and treat fatigue. Yeah.
Mm-hmm.
I think this is a sign that we have learned something, because also in autoimmunity, we have always talked about more effective therapies, but now it comes to the surface that there are also cardiovascular disease, infections, and so on. And I think it's the same with fatigue. We're treating our patients in a more or in a better way, and now all the other problems of these patients come to the surface, and I think it's very important to address these. Barker, I wanted to ask you, I mean, reading your amazing American Journal of Kidney Diseases review, there is basically, there are a lot of subheadings, as you also mentioned in your presentation, but I read all the time, there is something evidence for that, and then other studies have disproven that or have not shown that. What is the explanation for it? Is it the design of the study, retrospective nature? Is it studying different ethnicities? Or how do you explain that in general?
Oh, probably all of the above is the correct answer to that question. So the data about this topic, a lot of the studies are older. So we, the ways in which we deliver dialysis are different now than they were a few decades ago when some of these older studies were done. And so the degree to which those data apply to modern dialysis techniques, I couldn't tell you. Many of them were very small. And so to simply say they didn't show a difference might overlook that they could have just been underpowered. And there are questions about who we enroll. So I think we kind of circling back to something we've mentioned, that there are all of these different phenotypes of fatigue, and they're probably not all the same thing. And yet, if we're just asking people, hey, are you tired, and enrolling them in a study, then that might be capturing so many different issues that one single intervention might not really show you much of a total difference on average. And so you'll lose the signal in the noise. I think that all of those things are very important, and it takes going through the data with really a fine-tooth comb to pick out the issues with each study. So cumulatively, I think what we have are like some very interesting hypotheses with like some like small studies with decent supporting data. But I'm hopeful that we'll develop more of a large scale clinical trial mechanism to try to understand this a little bit better, because it's just very hard to know exactly what we can do for people in a targeted, individualized way with the data that we have.
If you would design a clinical trial now, what would be your preferred intervention?
Oh, that's such a good question. And I think about this all the time. So, like I said, I think we're getting it wrong to do trials of a single intervention, what, like a certain medicine versus placebo or what have you. I don't think that that's likely to move the needle. What I think will ultimately be more likely will be more like complex problems need complex interventions is basically the bottom line. I think that more complex clinical trials evaluating maybe a panel of interventions, evaluating patients for a certain number of issues and addressing those issues would be more appropriate than just a single intervention, if that makes sense.
I could propose an intervention. It would be kidney transplantation.
That's actually a really interesting point because fatigue doesn't necessarily go away after they get transplanted.
Yeah, but normally, yes. So my clinical experience, even at 2 to 3 weeks thereafter, they say I'm not anymore tired. So and they still have sarcopenia, and they tell me, "Whoa, it's gone away. It's gone away. I'm not anymore tired."
So even so, about 60% of kidney transplant recipients will still report fatigue in the studies that are out there about this. So it is, I think, inarguably a good thing to be doing for people for many, many reasons. But fatigue itself, it is not, purely solving the problem either.
Depends when you ask them. Maybe 5 years after transplantation, maybe not. Maybe they have some euphoria when they have high cortisol levels in the first weeks. So there are certainly some different confounding factors, but this is my routine experience if we do not transplant patients over 80 and things like that.
Just to defend dialysis, we see actually sometimes the same from people who have advanced CKD and then go to dialysis and tell us after some days, well, they feel like reborn once uremia is treated with dialysis. So surely transplant is the best option, but dialysis is also better than not being able to do anything like we have been 5 decades ago. So may I just briefly mention the other side of the coin, which is insomnia. So our people have fatigue during the day and then at night they have problems to sleep. I think this is also a tough issue because here again, to my best knowledge, there are no good data how to treat them. We just saw a quite large study which did not find any benefit in the sleep HD study with trazodone. So what are your ideas how best to help these people?
That's a really difficult question because as you mentioned, we don't really have great compelling data. And with all things in patients with kidney diseases, I tend to be very cautious about the risks, particularly of medications. So I'm quite hesitant to just prescribe something for these problems. And I tend to be someone who focuses much more on sleep hygiene and habits as a first step. And then again, getting back to exercise, that is another thing that can help people with their sleep as well, certainly anecdotally. And so I tend to opt for those options much earlier than reaching for another prescription in our patients who already have so much polypharmacy and so many side effects and other issues.
So I guess the same then applies for antidepressive medication, because you showed us in your CAST study that there's, at least for the majority of patients, no real benefit for antidepressive medication. There again, I guess you would be rather reluctant to initiate them by yourself as nephrologist, I guess.
So, my bottom line about SSRIs is that even though the data do not show that on average they help with depressive symptoms or fatigue, I think that they may be worth a cautious trial. But I tend to start at low doses and cautiously up titrate. If they're not experiencing benefit after a certain amount of time, then I would deprescribe. I think deprescribing is really key when thinking about using an SSRI. But if a patient is deriving benefit and they're not having intolerable adverse effects, it may be something that could help some individuals. I just don't think we've parsed out exactly who yet. We did have some secondary analyses of the CAST study that looked at, for example, patients with elevated baseline high sensitivity C-reactive protein were more likely to have a favorable treatment response to sertraline. So there may be something related to underlying inflammation that could help us select patients who might be more likely to benefit. But as things stand right now, a time-limited cautious trial is probably a reasonable thing to do.
Then going back to acidosis one second time. So you told us there are small studies with not really results that are fully convincing. Now we see these large phase 3 studies from Switzerland and from Canada, Baylor and Preserved Transplant, which did not really showed us any benefit. Do you believe that these large studies that now came out really put an end to the acidosis issue? Should we become more reluctant to give bicarbonate to our patients? That's what I do. Or did these large studies actually just were not able to answer questions on softer endpoints like fatigue? So are we able to answer the right questions for our patients with our large phase 3 studies?
I think that depends on who you ask, and different people will give you very different opinions about this issue. I know the upcoming KDIGO guidelines that have been circulated are really de-emphasizing treating metabolic acidosis. I believe the new recommendation is up until a bicarb of 16 now. It's like a very different treatment recommendation than the last set of guidelines. But talking to people who have a lot of expertise in acid-base physiology and hearing what they have to say about the role that acidosis has in generating damage to the kidneys, I think that crowd of people would be much more likely to tell you, I'm still going to supplement alkali to my patients. And so there's probably a lot of difference of opinion. Here. I think it's reasonable to argue either side. Now, as far as endpoints like fatigue go, treating acidosis is not a primary thing that I reach for to treat somebody who is fatigued. But if I can't identify anything else, and I think that the risk of harm is low, so, namely the sodium administration that comes with sodium bicarbonate, then I think it's a reasonable and relatively low harm thing to reach for in somebody who might be suffering, to see if it can help them out.
I'm interested in this long-standing battle between peritoneal dialysis and hemodialysis. Is there any difference with regard to fatigue?
Both experience a lot of fatigue. In terms of hemodialysis, there is a question about whether they're fatigue related to the dialysis treatment itself may be, a particularly meaningful thing, or whether just their cumulative experience of fatigue is the more important data point. But fatigue is still very common among patients on peritoneal dialysis as well. And it's something that I think we know a little bit less about in terms of, hemodialysis. We can think about the fluid shifts and the myocardial stunning, but on peritoneal dialysis, I have read less about, more specific treatment related mechanisms that could be contributing there.
Mm-hmm. Okay.
I have one last question from my part on nutrition. So I'm the oldest of the four of us. And for 3 decades, I have learned that we should teach our patients to avoid large variety of food, particularly those rich in potassium. And there has been quite a change in the last years. Do you believe that if we become more lenient here and allow our patients to have broader access to food, particularly to those kinds of food that we generally consider to be healthy, that this might also affect depression and fatigue in these patients, or are these two different issues?
I do believe that, but I wouldn't say that it's adequately substantiated by data. So especially in patients with earlier stages of non-dialysis CKD in whom you're less concerned about the potassium content of food, if we're recommending that they eat a heart healthy diet, which includes a diet rich in healthy fruits and vegetables, then I think doing better for their heart will ultimately help their cumulative experience of fatigue over time. And if we can liberalize our potassium allowances for people to give them more healthy fruits and vegetables and all of the other things that are so good for people that come with that. It's an alkaline diet. It has a lot of dietary fiber. There are so many things that are good about that. I do think that we'll see that helps, but the data aren't there yet. That being said, so the data that do exist show that fatigue is associated with malnutrition and things that are like that are more severe forms of malnutrition. And I am curious if we can get more nuanced data that look at dietary intake choices and their impact on quality of life and fatigue.
Parker, thanks so much. This was great, and you really gave us a lot of new ideas on the best way to treat our patient and also to address their real concerns. So thank you so much for joining us. Thanks for doing all these studies. We're looking forward to hearing and reading more from you and hopefully to meet you once again in the future. Thank you.
Well, thank you so much for having me. It really has been such a treat.